Dr. Swanson. She really doesn't need any introduction, but she's accomplished quite a great deal. She did her BS at Tulane in mathematics, then went on to University of Washington for a master's and PhD. She did a postdoc in mathematical neurooncology at UCSF. She was on staff at University of Washington before eventually joining Mayo Clinic, Arizona in 2015 as vice chair and professor, and very excited to hear your talk.
Well, thank you. Our ethos within the lab is really this driven. People always ask me, what's the title for your talk? And it's always the same title. The content may be different, but the title is always the same, because this is what our belief system is that every patient deserves their own equation, which is exactly where Leland just ended, right? That you have to optimize for each individual patient. And frankly, clinically, we lack sufficient numbers of decision support tools to be able to help and guide that precision. And so I'm going to tell you about some of the ones that are coming down the pipe that you should expect to see fairly soon. So, we all know this major problem, right? We understand the problem of brain tumors. We have some sort of histological diagnosis associated with some sort of image. As Leland nicely highlighted, that biopsy, that specimen that you're looking at under that microscope could have come from really any location within that lesion. And the net result is this histology generates the diagnosis. And in the middle is there's some sort of treatment, but because it's the brain, we're going to be limited to using imaging and relying on imaging a lot to be able to make our next decisions about that individual patient's care, because we're not going to get a lot more of that tissue that you see under that microscope. So imaging really does drive clinical decision making, but imaging reveals only the tip of the iceberg of the disease. And what we mean by that is this is a diffusely invasive disease, right? So what you see on the top is the MRI, tip of the iceberg. This is like a routine T1 gadolinium-enhanced weighted MRI. And what you see on the bottom is the actual diffuse extent. And intellectually we know this, but we need, and this is where my group started, was building a framework to allow us to take in as inputs this MRI level understanding of the disease and predict out an accurate patient-specific prediction of where that diffuse gradient of tumor invasion is. In this visual on the bottom, red is low cell density and white is high cell density. So you biopsy in the white region and you basically run into only tumor cells. It looks like under the microscope, frank tumor. If you biopsy in the red region, there's an occasional tumor cell that any two neuropathologists will debate about how many tumor cells that are there. So the pragmatic, this is one pragmatic question that we understand as a problem within this disease, but building tools to be able to connect the dots from the MRI to this actual diffuse extent is one component. Another horrible, challenging component of this disease is the wild heterogeneity across patients. So these are 15 seemingly identical, at least under the microscope, glioblastoma patients. And they're going to receive standard of care radiation concurrent with temozolomide